Hey everybody, I'm here today with my friend Lee. You're gonna love this interview. He is a nurse practitioner who's been out in the world practicing as an NP for 6 years now, 2 of them in inpatient rehab, which I think is a specialty that not many people know a lot about, myself included. So I'm super interested to get to this interview and highlight another specialty that you can go into with your acute care. If we haven't met yet, my name is Bree. I'm a nurse practitioner. I make content for nurses, NPs, and students. Welcome to the channel. Okay, so let me start with asking you to tell us a little bit about your background.
So undergrad nursing, I finished first initially with an associate's degree in nursing in 2010. I started working as an RN.
Which is the
did some night shift stuff. You know, a lot of people start on night shift, so I was doing night shift and going back and got my bachelor's, and then started my FNP program at Bernal in 2013 and graduated in 16, and then started working as a family NP in a walk-in clinic. The little clinic is similar to the minute clinics and those kind of things. And then decided I wanted to work in the hospital setting, so I needed, as an FNP after the year 2015 in the state of Georgia, you need acute care to work in the hospital. So I went back for postmasters, and as far as family NP, I did that at Bernal, and then my postmasters I did at Emory for adult general acute care.
Yeah. Lee and I, okay, full disclosure, Lee and I have known each other for a very long time. So I've seen this entire journey go down. And he is one of so many people that I know that like worked in a hospital and went straight to that FNP route, which I'm just always curious about why people do that. And like many, they end up going back for their acute care. So I want to talk about that just for a minute. Why you initially chose the FNP route.
So initially, FNP was good for everything. In 2012, 13, when I was looking at going into becoming a nurse practitioner, we had FNPs working in critical care in the ICU when I was there, a brief stint in the ICU, and we had FNPs all through the hospital, and so FNP was kind of, you went there and you could kind of work anywhere. So midway through my FNP program, then they came out, the state board
so you
said,
were right, and you were 2015.
State board said, no, you need to be acute care certified if you're going to work in the hospital.
You got hosed.
I was a year and a half in, and they were like, okay, well, all right, that takes away those prospects. But so that's why I knew there was a possibility that I probably wanted to go back into the hospital. So after I got out and started working as an FNP, I was like, okay, I'll do this for a couple years and go back and get my postmaster's certificate so I can get certified as acute care.
So I know there are a lot more FNPs out there in the world than there are acute care NPs, and a lot of them are on my platform. So tell me a little bit about your little clinic experience. Like, what did you enjoy it? What was it like?
So Little Clinic was actually really good as a newbie novice NP. So there is actually exceptional amounts of autonomy at Little Clinic, because my collaborating physician that oversaw my work was actually out of state. Never saw him, came in and reviewed my work periodically, and had to check off X number of percentages of my charts, and chart reviews and audits, but hardly ever saw them, hardly ever spoke to them. So that first year as a new grad was
kind of scary, actually,
daunting.
right?
Yeah, you did, because you're in a clinic there and by yourself. So
who do you go to for questions?
Yeah, you can call if you can
Hippocrates and up to date.
If you can get in touch with your collaborating physician, it's sometimes easier than others. You can call them and ask questions, but that first year, me and Up to Date got real familiar. So I can navigate through Up to Date and quick skim hit the high points really well now. The Little Clinic stuff, the walk-in stuff, you have such a very narrow scope, a limited scope. So you don't get to see all that much, but it didn't take long working there until you started to feel pretty proficient.
Sure.
Because there was such a limited scope, it didn't take long to kind of feel competent doing it.
Gotcha.
Maybe even as a new grad working, every time you start, and I've noticed this starting as in PM&R, you have some of that imposter syndrome kind of thing where you're like, I don't really know this as well as I need to know this in order to be taking care of these patients. Kind of feeling that you kind of have to work through. But within 6 months, as an FNP at a little clinic, I felt very competent. It took a little bit longer, probably doing the PM&R here in the hospital, just because the scope is a little broader. You see a little bit more stuff. And the patients are a little higher acuity because they are still in the hospital. So all of that kind of served to make it take a little longer for you to start feeling.
Hey friends, sorry, I wanted to take a moment away from your video and talk to you about some of the challenges that I faced when I was transitioning to becoming a nurse practitioner. Everything from deciding whether or not I could go back to school, to where I should go to school, to what I should specialize in. Really struggled with that phase of life. There were no professional mentors to help guide me. I also struggled with my onboarding, and I stayed late every day for 4 months just trying to get my notes done. This changed once I recognized the power of using dot phrases and automating my work. What I recognized with having NP students for the past 5 years is that everybody struggles with these things. It's not unique to me. Everyone has these same challenges. So I created a business. I have a website. I would love it if you would go check it out and see what services I have that could help you in your unique set of problems. Anywhere from college choice, resume reviews, one-on-one consultation services. I'd love it if you'd look into my book. This is the book I wanted when I was new and when I was a student. It's the Ultimate H&P Cheat Sheet, a copy of the 12 most common ICU problems with plans and templates. So it's like a copy that you can put in your EMR and your dot phrase, as well as a behind the scenes on what I teach my students. So a little bit of how we make the diagnosis and what the pertinents are. So I think it's gonna be very, very helpful. There's an e-version that's very affordable, and there's this hard copy that I will be happy to send to you. I also have noticed as an NP in a competitive market, in a program that interviews people a lot, when we have an open position, we can interview anywhere from 5 to 10 people, y'all. And apples to apples with the same level of experience and not knowing you, if you're coming in and you are unknown to us, the person who interviews the best is gonna get the job, period. Because people hire for personality, believe it. And the way you let your personality shine is by preparing and practicing your interview skills. What better way to do that than with a person who does this all the time in the profession that you're looking to join? So when you sign up for a mock interview with me, I am going to hand tailor a set of questions uniquely designed to target your weaknesses within the field that you're looking to go into. So we're going to do 30 to 45 minutes of questions followed by 15 to 30 minutes of review so that you can hone your skills, continue to practice, and when you go in for your interview, you can feel confident and let your personality shine. And this, friends, is what's going to get you job offers. So if you've been going to interviews and not getting offers, this is likely the reason. This has the power to reap massive rewards. So again, let me just take a minute and say I appreciate you. I thank you so much for watching my videos and engaging in my content. And if you want to take the next step and check out my website, I would be ever so appreciative. Thank you all so much and good luck on your career journey.
Tell everybody out there what PM&R, M before N or N before M?
PM ampersand R.
What does that mean? I don't even know what that means.
Physical medicine and rehabilitation. So, or just rehabilitation medicine, you can say it that way. So what we do in PM&R, and it's something that's kind of a very small specialty. There's not a lot of it out there, but what we do is it's a focus on more restorative medicine as opposed to curative medicine. When patients come initially into the hospital, you're trying to fix what's wrong with them. When they come to us, whatever has happened to them has caused problems with their functional independence, their ability to complete their tasks of activities of daily living, that kind of thing. So our focus is more on restoring that patient to their optimal level of care. So trying to increase their level of independence, increase their ability to perform their activities of daily living, and there's a lot of different diagnoses that patients have when they come into the hospital that end up resulting in some form of debility, so that it gives us something to kind of try to tune them up as much as we can before we send them back home.
Yeah, it's a bridge, right? So what made you decide, maybe we skipped over this a little bit, what made you just switch and decide to go back to the acute care and get into the hospital?
It was primarily that limited scope, working in that walk-in clinic type setting. I kind of thought I wanted to work in the hospital all along, and that was kind of going to be my focus, was my plan, and then that kind of got interrupted, and you had to, once I graduated, you got to find a job somewhere. Luckily I didn't have, 2016 was different than it is now. When I first graduated with my family NP, I didn't have trouble finding a job, but slid into something, and it was kind of just going to be something for me to try out and see. I didn't have any plans of staying there for a career, making a career out of it. So I kind of knew all along that I wanted to be in some way, shape, or form back in the hospital. So it was kind of, once they came down with that recommendation, even after I graduated with my family NP, I knew I was going to be going back to get my acute care.
But now you're like perfectly versatile. You could do anything, right?
Yeah, it works out well. You know, I can see kids. That's within my scope as a family NP, and that serves me well because in the clinic setting for PM&R, I can see children that some of the other providers aren't as comfortable seeing. So, these little kids playing sports, concussions and bones and joints and non-surgical, anything like that, I'm pretty comfortable seeing there. So it has served me well, for sure.
It seems like it kind of borders on like sports medicine.
It's very close. So sports medicine in general, I'm pretty sure is also non-surgical primarily. So it's we do a lot of the same things when it comes to bones and joints and aches and pains and things like that. So it's PM&R is a non-surgical specialty. So we'll treat a lot of lumbar, thoracic, spine complications and problems, back pain, a lot of that. We'll also do a lot of, in the office you do a lot of joint injections and things like that. So very similar to a sports medicine type. And then there's also, as far as the follow-up with patients that are debilitated following things like strokes and brain injuries. There's a lot of spasticity issues, so some of the providers get some specialization in like Botox treatments for spasticity and things like that that they'll do in the office as an outpatient in the clinic setting.
So do you do a combination of clinic and inpatient?
So when I first started a couple years ago, yes, we would come, we run the inpatient rehab unit in the hospital, and we would go round on the patients up there, write notes, and then we'd go back over to the office, see some patients in the office, and then come back in the afternoon and do admission discharges, some consults here and there, that kind of thing. Now, as the hospital side, inpatient rehab side has gotten busier, it's myself and another nurse practitioner. We're there primarily in the hospital all the time right now. So we still round in the morning and see the patients, write notes, go see consults, and then a lot of admission, discharge stuff. And then we, myself and the other NP, are the two providers that are managing the day-to-day of the unit there on the rehab floor.
Gotcha. Okay, let me ask a little bit about your schooling. So you went to Emory, you went to Brenau. Did you feel prepared? I mean, we talked a little bit about your little clinic experience, but when you transitioned to the inpatient role, did you feel like you were prepared and ready?
No, no.
I'm glad you said that, because if you had said yes, I was like, dang it.
No, neither time really, but and it's just because they were different. As far as trying to get started, there's a huge shift when it comes from working as a nurse to working as now you're a provider. So that you go from following orders to being the one to try to come up with a treatment plan and coming up with what needs to be done for the patient. So that's a huge shift. So trying to get used to that is hard. It's very hard to switch from your nursing mindset that you've been doing for several years into now, okay, I have to shut that off, and now I'm a provider now. Right. So, we touched a little bit about that imposter syndrome kind of thing. Definitely have some of that, but the book stuff, you just kind of have to keep telling yourself, hey, I passed these boards. I'm board certified. I have demonstrated my competency level in testing form. So I know that I know what I need to know in order to take care of these patients. It's kind of, you have to do it. Once you get in there and you start doing it and you realize, okay, it's not this big scary thing, then it becomes easier. But when you first start, I don't think I've talked to anybody that has said,
very few. Very few.
When I started, I was ready.
It's a piece of cake, man.
Nothing to. I don't think
they're liars. They lie.
No, it doesn't matter. Where you went to school, how good your schooling was. That shift from nurse to provider is massive, and I don't think anybody just takes to it right away.
I ask that because I hear from a lot of people that I talk with that this almost crippling anxiety of not being able to provide the care that you're expected to provide is very challenging. And many people end up second guessing themselves and even their whole career choice. And so they scrap things and go back to working at the bedside. And I just tell them, just hang in there, like 6 months until you're not white knuckling the steering wheel driving in. And then a year until you're like, okay, I can take a deep breath. And then 2 years until you're like, you know what, I've pretty much seen everything at this point. I'm pretty comfortable with everything. And I think that's really just because we are nurses. We have been working at the bedside, as you said, carrying out orders and thinking through some things, but not to the extent as you would if you were the person placing the orders. So that burden is very, very high, and I think most people underestimate it when they graduate. They don't realize the liability and how much it weighs upon you.
The level of anxiety knowing that you're responsible for, what I just decided was, okay, that's the diagnosis I came up with for this patient, and this is how I'm going to treat it, and what if that was not even close?
I know.
Right. That weighs on you for a while, but then that goes away.
And I think it really helps to have a really good collaborating physician because, part of the problem with this is that we are learning medicine without going to medical school and without doing a fellowship. Most NPs are not doing fellowships. So you're going straight into a career that, as Lee said, you are board certified and you've been taught this information, but recalling it is very, very challenging. Yeah, so it can be a lot. That first year is a rough period of time for all of us.
Yep, across the board. Doesn't matter what your specialty is. Doesn't matter, where you did your training. It's tough. It's a tough transition for sure.
Yeah, I agree. So tell me a little bit about your schedule. How does your schedule work?
So my schedule is Monday through Friday primarily. Actually, we're in a little bit of a transition too. It's typically 2 physicians and 2 nurse practitioners that manage the unit, and so it has been we don't have any night coverage, so when
somebody's got to take call.
When we're on call, we take call every 4th week, and your call is Monday at 7 a.m. until the following Monday at 7 a.m. So
crazy. Like all week long?
Yeah.
So you're working during the day and you're taking call all night long. And do you get a lot of calls throughout the day?
Luckily, no. For the most part, the nice part about physical medicine rehab is most of our patients are relatively stable. Otherwise, they aren't able to tolerate the required 3 hours of therapy that you have to do every day in physical medicine rehab. But you still deal with the same. You're still dealing with the same diagnoses that these patients had when they were, initially in ICU and then moved out to the floor. So these patients still will occasionally go bad, and they still will, have seizures and still have those kind of things. So when you do get called during the night, it's not like if you're relating it to like a cardiology call or something like that, where they're called all the night long, nonstop. it's not nearly that bad. But
Okay.
by the end of your week, you're ready
Exhausted,
you're ready to
I'm
not be
sure.
on call anymore. But yeah, so it's every fourth. You have a call week, but we're Monday through Friday, and then on your weekend that you're on call, you round on the unit. So we round.
So you work a fair amount.
Yeah. So every fourth weekend, you're
Yeah.
rounding on the unit. Seeing all the patients and writing all the notes and that kind of thing. So it's doable. It's but it's not a 36-hour a week job for sure.
It's a trade-off.
It's a
I mean,
good
I know a lot of people who want that, that routine of the 8-hour day, and they're home at night with their kids for dinner, and they can go to sporting events. I mean, there's a definite appeal to it. So I can see that.
And so that part is definitely nice. By about 4:30 every day, I'm usually done and on my way home. So, the day starts a little early, but that part is nice. Definitely having that routine set schedule is easy because you get used to it and you start kind of working around it. It's kind of difficult if you need time off during the week for something. Say you got to take the car to the shop, or you got to have a doctor's appointments or whatever. That can be kind of difficult trying to fit that in. But the Monday through Friday thing is not bad. On the whole, it probably would be easier maybe if it was like a 410s or something, but that's just not the way it's set up for PM&R.
Yeah. Okay. So how is your autonomy like in PM&R?
So we have a good deal of autonomy. Myself and the other NP are the ones that run the unit during the day. So we round in the morning. We round with the attending physician. We have one attending physician right now for the whole unit. So we round with them in the mornings, and then the rest of the day, that physician is in the office seeing patients in the clinic. So myself and the other NP we manage the unit during the day with what's going on. So that's going and seeing consults for potential new admissions, handling all the admission discharge stuff, and then just whatever's going on with the patients. When they're working with therapy, or they're on tele and they have some arrhythmias, that kind of thing. You're
kind of doing almost like a hospitalist role. You got to know a little bit about a lot of things.
Yeah. So as far as our patient mix, that's kind of what's nice with PM&R, is because we see a lot of different things. So about 25% of our patients are stroke. We are a stroke center.
Yeah, that makes sense.
About 25% are stroke. Another 25% or so, I think, are orthopedic injuries. So that would be like long bone fractures, MVAs with multi-traumas. Then another 25% or so are a combination of spinal cord injury, traumatic brain injury, and then neurologic disorders like multiple sclerosis exacerbations, Guillain-Barré, that kind of thing. And then the remaining is a combination of amputations and other like critical illness myopathy patients that are just very debilitated from having prolonged illness, that kind of thing. So you see a pretty wide variety of patients, which is kind of nice. Like I said, that scope is a little wider. So as far as and we are there attending, so we are managing kind of everything that goes on with the patient when they're on rehab.
So you don't do any kind of vent weaning or trachs?
We do take trachs. So we'll take trachs. We take trach collar patients and work on weaning towards getting those trachs removed. The goal is to have that out before they leave and go home. So a lot of times when patients are on super high flow with their trachs and trach collars, they're not quite ready yet for inpatient rehab because they got to be able to tolerate that 3 hours of therapy. And when you're on high flow and you desat as soon as you sit on the edge of the bed, they can't really work with you for a long time. So they got to be starting to get a little bit more robust. But no, we do take trachs and trach collars and do work on getting them weaned.
Okay, very interesting. Okay, let's talk about a little bit of professional stuff because the people want to know. Inquiring minds want to know. Do you think that the market is saturated?
Yeah, I think it's
I love asking this question.
It's starting to get that way. That's not to say that you can't find a job.
Yeah.
If you graduate with your NP, you might not find your dream job right away when you get out of school. And if you'd asked me that question maybe even 2 years ago, it might not be the same answer. But I think what we're seeing too with COVID has changed things so dramatically. There is so many nurses that are getting burnt out with bedside nursing, and they're looking around and trying to figure out
what else can I do in life?
What can I do now? And well, I've got this nursing background. Okay, well, let me just go to NP school. And there's a lot of people that had NP school as a goal to start with. Nursing was kind of something they had to do in order to go to NP school, and I kind of even fell under that same umbrella. But I think there's so many people, and maybe even another year or two, when all these nurses that have gotten burnt out with bedside nursing that went to NP school that are going to be graduating, it may be a whole lot tougher. But in our area, it's starting to get pretty saturated. But that's not to say you can't still find a job, whether you want to do acute care or you want to work in the outpatient in the clinic setting. There are jobs out there for sure all the time.
Yeah, I always say, I don't like the term saturation because it implies that you can't find anything. There is more supply than there is demand, but ultimately you hit the nail on the head. It's like all your motivations, right? If you're going back to school because you want to make more money or you're burnt out at the bedside, you are setting yourself up for a world of frustration because you're not going to come into something that's going to automatically earn you more money or give you more job satisfaction. If you're going back to school because you desire a different relationship with your patients, that's the right answer, because you will fight for what it is that you want, and you will tough out those phases where you don't get your dream job or you settle for a little while until you can get there. The people who are going into it for the ease of it or something else, they're going to quit.
Yeah, no, that ain't it.
This is way too hard to do.
There's definitely not an ease of it. It's just, it's not the same as bedside nursing. It's just different. But
that's exactly right.
Yeah.
People think, I'll go be a provider because it's easier. No, sir. Your brain will literally smoke at the end of the day, and it will be so stressed. The burden of being responsible for people and making decisions every day, decision fatigue. It's real.
Tough. And note writing, you can go see all the patients you want to see and see all the consults you want to see, but then all that has to be put into chart form, has to be put into the computer system, and has to be documented, everything that you did, and that takes time.
Yes,
so
it does.
And there's a finite number of hours in the day, so it is tough to get it all in sometimes, and especially when you're first starting. It is tough to get that documentation done. And that is a huge area of stress.
I think so too, and I think people don't realize it. These friends already know my soapbox. This was my biggest thing, is that I knew note writing would be challenging, but I didn't realize how challenging. And it wasn't until I realized I could use dot phrases to automate things that things started to get better. But I was at work every single night. I was supposed to leave at 8. I left at 11 o'clock every single night for 4 straight months. And I thought, this is the biggest mistake in my life, because all I do is write notes all day, and I can't even figure out how to do that right.
Oh yeah, yeah.
Note writing is so hard.
You don't think it would be that hard to get your ideas down on paper, so to speak, but everything that's up here just sometimes doesn't come down very very fluently or easily, and it's just dot phrases are the way to go. Thank you,
Go get my book. Shameless plug. So how was it for you in job finding?
So it was, for me, initially, I had a job lined up with my walk-in clinic before I took my boards.
That's nice. Because, did you do clinicals there, or how did you have it?
No. Your best friend, aka my wife, it works for Kroger and New People. So
you had strings.
You had people that were known.
Networking people. Networking.
Yeah. So you put in the good word for me, and then but you still have to go interview, and so you still have to you have to, when you go talk with them, it has to be a fit, and that's important. So personality is huge, but that was definitely beneficial, because I knew even before I sat down and take boards that all I had to do was go take my boards, and I had a job waiting on me.
Yeah.
So that was
pressure
nice.
off. Sure.
And then once I got done with my acute care, I didn't have a job waiting on me. So it was kind of just trying to find something that I was interested in. And I interviewed a couple of different specialties. I knew I kind of wanted to get back into the hospital. I wasn't sure maybe if some type of surgical specialty might be something I was interested in. Interviewed a few different places, and they for whatever reason, we're looking for something else. A couple of different times they were looking for somebody that was already had experience in that specialty, so they didn't have to do a whole big onboarding, teaching kind of thing, spending 6 months or a year trying to teach you how to do what they wanted you to do. And then it just so happened there was an opening in PM&R, and I had worked in inpatient rehab as a nurse for a couple of years early on. I did multiple different things as a nurse in multiple different areas, but so I was kind of familiar with physical medicine and rehab from having worked in inpatient rehab as a nurse years back, and so that ended up working out.
So do you earn more as a nurse practitioner than you did as a bedside nurse?
That's another good question for now versus a couple of years ago. But yeah, absolutely. When I first started as an NP, I was so I graduated nursing school and started working as a nurse in 2010, and then started as an NP in 2016. So I'd been working as a nurse for 6 years. And definitely I made more as an NP, especially hourly rate and that kind of thing, than I did working shift work as a nurse for sure. And now that's, nursing shortages being what they are.
I know, nobody makes more than nurses.
Yeah.
Doctors don't make as much as nurses do now.
There's some interesting memes that are out there. All the Lamborghinis in the parking deck at the hospital are actually the travel nurses working those contracts. So that's a different answer right now than it was a couple of years ago. But,
right, that's valid.
In general, absolutely. If you are kind of tapped out as a nurse and you've been a nurse for a long time, and then you decide to go back and become an NP, it might be pretty close. Salary wise, you might really, and you could even conceivably make less, especially if you worked nights and weekends and had all those differentials baked in there. But for me, I worked days, and I'd been a nurse for 6 years, and I made more. Yeah,
same here. Okay, thank you so much. That was awesome. I'm so glad that you came and shared all your wisdom.
Absolutely. Thanks for having me.
All right, talk to y'all later. Bye, friends. What should we talk about? I got nothing.
Charcuterie report.
You're doing great.
Oh, hey, just
you're a professional.
Sliding through, winging it. Well, let's see.
No pressure whatsoever. Okay, hey everybody, I've got a fabulous interview for you today. I just got like a little spitball. See, 2 seconds into it. That's how it goes.